On behalf of Boston IVF, we're pleased to host today's webinar, Genetics and Fertility, presented by Dr. Keri Bergin of RMA of Southern California. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Now, without further ado, I would like to introduce today's speaker. Dr. Keri Bergin began her journey at the front desk of a New York City fertility center before advancing to IVF coordinator and later earning her medical degree from Thomas Jefferson University. She completed her OBGYN residency at Albany Medical Center and a fellowship in reproductive endocrinology and infertility at RMA of New York, Mount Sinai Hospital. A passionate advocate for advancing patient care, Dr. Bergin has presented nationally and published research in leading journals, including Fertility and Sterility, JMIG, and IJGO. Based in Los Angeles with her wife, she is committed to advancing inclusive fertility care for individuals and couples, including those in the LGBTQ+ community. Dr. Bergin offers expertise across all areas of infertility and assisted reproductive technologies with a special interest in the role of genetics in reproductive health. We encourage you to submit questions to Dr. Bergin using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. All right, we're going to get started, and I'm going to pass it over to Dr. Bergin.
Okay, thank you. So yeah, I'll talk today about genetics and fertility, or genetics and reproduction. Genetics plays a key role across OBGYN. It's becoming increasingly important in preconception, infertility, and prenatal care. Genetics as a field is growing across the board in medicine, and that means in OBGYN as well. So my goal today is just to provide some insight into this field and how it relates to reproductive medicine and OBGYN practice. I think that patients are coming in more and more frequently for preconception counseling appointments. They're coming in for fertility checks and wanting to talk about, preparing to get pregnant, which is a great thing. And there's a lot of kind of health and wellness things to talk about at that visit. But I think it also just opens up an opportunity to talk about bigger picture family planning. And, obviously there's not one fertility test, but I think what patients are asking is, how can I really set myself up for success for my future family building? And part of that involves genetics. So thinking kind of broadly about the 3 ways genetics relates to the preconception and counseling appointment, talking to them about the genetics of aging in general, kind of do they understand that there is an age-related decline in fertility and how aneuploidy increases with increasing age, thinking about what their long-term family building goals are. How old do they think they'll be when they're trying for baby number 1, baby number 2, number 3? How important is family size to them? Because depending on that timeline, understanding the genetics of aging, do they want more information about egg or embryo banking for their future? Carrier screening is the next way genetics comes into play with preconception. So, a lot of patients, I think, will feel like, oh, I don't have any family history of a certain medical disease, and so I don't need to do, carrier screening. So making sure they understand that there is risk for these diseases despite having no family history, and understanding the implications of finding out carrier status before versus during pregnancy. I think a lot of patients come in during pregnancy and then get carrier screening done. And I think that's a missed opportunity to have offered it to them when they were starting to think about building their family, knowing that there's options and different paths they can take depending on the results. And then lastly, family history. So just kind of thinking about family history, whether there's certain cancers that run in the family, certain patterns of disease, does it warrant referral to a genetic counselor in general? Or do they have a parent that is known to have a disease, an autosomal dominant disease or some sort that the patient doesn't want to know their carrier status? And do they have options though for trying to lower their risk of passing that down to their offspring? So those are kind of the 3 things I'm going to mostly talk about. But first, to think about the different methods for genetic testing, which have really evolved over time. First, when you think of genetic testing, you often think of a karyotype. So for a karyotype, you need a lot of DNA, a lot of cells, and they need to be alive so that you can culture them and they can be dividing, and you need metaphase chromosomes to actually stain them and see large, deletions, duplications, translocations. There's microarray testing, and these are the types of tests or the methods for testing, not the specific ways that they're being used. But the microarray testing, you're generally taking patient DNA and a reference DNA and then hybridizing it to probes on the array, and then looking at the different signal patterns from the patient labeled versus the reference labeled DNA and comparing the relative gain or loss of DNA, whether that's a segment of DNA or whole chromosome DNA, and seeing if there's, gains or losses. And the resolution of these tests depend on the amount of DNA that you're putting in. So when you think about microarray testing for something like an amniocentesis sample versus PGT, the resolution of those are going to be very different, but generally can get pretty small in the kilobyte range for prenatal testing, like for an amnio sample. And then there's next generation sequencing, which is what's used in a lot of modern kind of tests. And I'll talk more about it as we go into the PGT, but this is where you're taking often, depending on the type of test, but amplifying the whole genome and cutting it up into small pieces and attaching it to a different adapter. So it's unlike PCR where you have to know the primer to amplify it, the DNA, you're kind of attaching it to universal primer so that you're able to amplify it and then classifying or mapping the DNA that's amplified onto specific chromosomes. And then again, getting the relative amount of each chromosome based on how much of the DNA amplified. And I'll talk more about it for PGT. And similarly for SNPs. So there's, millions of SNPs that we have that are just specific locations where one base pair can be different for different people, and generally they're biallelic, so it can either be one or another, and looking at the kind of unique patterns of someone's SNPs is very relevant to some of the genetic testing that we do. Okay, so now starting with preconception carrier screening. The goal of carrier screening is really to identify couples that are at risk for passing on diseases. And so generally that means autosomal recessive diseases or X-linked conditions. And, we'll go through the different panels or kind of general panels, but this allows patients to make informed reproductive decisions before conception. So when they're presenting for that preconception visit, it should really be a part of what you're talking about, whether they want this information so that they can see if them and their partner are at risk of having a child affected by one of these diseases and what they might do with that information. So, whether that be they decide to use preimplantation genetic testing, do IVF to test the embryos, or they do diagnostic prenatal testing to find out if they are carrying a child affected by it, make decisions based on that. Or if they just are educating themselves about what that disease is, despite knowing their risk and being prepared for the possibility of having a child affected by it. So I think that it's not all about eliminating diseases. It's also about empowering people with information to make decisions or to know what to expect in their pregnancy or child. And the ACMG, the American College of Medical Genetics and Genomics, and ASRM, they recommend universal ethnicity neutral screening. And ACOG kind of generally does too, they're kind of back and forth, or they say you can consider ethnicity based, you can consider some of these more expanded carrier screening options. So ACMG broke down the different carrier panels into these different tiers, with tier 1 being very limited panel, cystic fibrosis, SMA, and risk-based tests. Tier 2 includes diseases that have a carrier frequency greater than 1 in 100. These include severe and childhood onset diseases that, again, are kind of more common in the population in general. And then tier 3 is what we consider expanded carrier screening. And this generally includes over 100 genes or so. But there's panels between 1 and 400 that look at diseases that have a carrier frequency greater than 1 in 200, often have childhood onset, can have severe consequences, or can be clinically actionable by early intervention. And then tier 4 is ultra expanded, less common diseases greater than 500. It does include severe but more rare diseases as well. So in general, ACMG recommends all patients be offered tier 3, what's considered expanded carrier screening, but there really is a move towards removing the term expanded and just calling it carrier screening. Patients should be offered this, according to the ACMG and in general, because they deserve options, and they should be offered in an equitable way where we're not just, targeting people that we think will make a decision or have the means to make a decision about what they do. And also not making judgment on what people might want to do in certain situations. So in general, we recommend tier 3 expanded carrier screening for everyone. And again, this is a move away from ethnicity-based screening because often patients' self-reported ethnicity or race is very different than their genetic ancestry, and there's studies that look at this. And so it's really hard to predict what panels are appropriate for patients based on self-reported ethnicity or race. So it's really just more equitable and able to capture more carrier couples by doing these kind of ethnicity neutral universal screening tests. The technology behind expanded carrier screening has changed over time. So in general, next generation sequencing is what's used. They're able to do like targeted enrichment of the specific genes to amplify the ones that are being looked at, and then sequence hundreds of genes simultaneously with some supplemental methods for certain variants. But this is different than what has been used in the past, where it was specific genotype testing. So where like in old panels, you would see like cystic fibrosis tested for 97 mutations. So rather than doing specific mutation testing, they're actually able to sequence the genes and provide information about whether it's a pathogenic or likely pathogenic variant that's detected. Variants of unknown significance or likely benign or benign variants are not reported on the report, but likely pathogenic or pathogenic are reported. So with that being said, you need to understand what kind of counseling patients need before and after testing. So just to explain that these are, autosomally recessive. So the way that inheritance pattern works, or X-linked, the limitations of the test. And so even though it is sequencing, it's generally sequencing the exons. And so there can be some rare intronic variants or kind of promoter or upstream mutations that can affect the expression of a gene. And so it's not necessarily going to capture every single variant that can cause disease, although again, it's capturing really the most common ones. But knowing that the results of not being carrier couples lowers the risk and doesn't eliminate any risk. Also that while they might be at low risk for the diseases tested, this is obviously not all encompassing, and there's still risk for diseases that are untested. Again, the possible outcomes, pathogenic and likely pathogenic, so not reporting other variants. And then discussing reproductive options if both partners are carriers. And again, this is more with the genetic counselor, but it's good for patients to know, what are their options should they both be carrier couple, they'd be a joint carrier couple. And one of those options is IVF, the testing of the embryos. Another is using donor gametes. Another is getting pregnant and then doing diagnostic prenatal testing early. And another I didn't put on here is adoption. So some of the considerations, there's no agreed upon panel of number of genes. So I think that can be a little confusing. So while the ACMG has kind of made this tiered system and sort of has this like minimum number for tier 3, the panels that kind of fall into tier 3 are often even more genes than that. And so a lot of places will do 300, 400 genes. And it makes it hard to know which panel is right for you and for your patients. But working with a lab is a really helpful way of like seeing what kind of panel they offer and what kind of counseling they offer, or how you can deal with results. It's also important then to test the couple for the same panel, because you want to make sure that they were tested for the same genes. And if they were tested for different panels, you want to actually specifically look at the report and make sure that the gene that one of them is a carrier for was tested in the other panel, which is also an issue, and it's kind of lower down here with donor egg and sperm panels. So we find at some of the donor banks, the panels that are used might be different than the panel you're using at your clinic. And so that's important in making sure that you're picking people that are not matches. Again, there's only pathogenic and likely pathogenic reporting, which is, ultimately a good thing. It does mean that there are variants of unknown significance or, but likely benign variants that could be reclassified down the line if more information comes out about their pathogenicity. So something to keep in mind. There are some conditions that have carrier phenotypes or manifesting carriers, as they call it, but luckily it's the minority of the genes that are on the panel. But for some genes, there are some mild conditions related to the disorder that even a carrier can have. And then there's some risks that are unrelated to the disease, but that carriers can have. And so understanding what those are and reading the reports and having a good genetic counselor to follow up with patients if needed is important. It's also important to consider the implications for relatives who might be building their families. And then ultimately, like I've said multiple times, really offering carrier panels is about reproductive autonomy, informed consent, and equitable care. And I think it's an important thing for patients to know exists, and not just for patients who are knowing to bring it up to their providers. So when we think about carrier screening in a general OBGYN practice, I don't know if all OBGYNs are comfortable ordering some of these expanded panels, but obviously once patients are pregnant, most OBGYNs are ordering carrier screening to some extent, whether that's tier 1, tier 2, or tier 3. And so first of all, shifting that from prenatal testing to preconception screening, I think is important. Patients coming asking about getting pregnant should be offered this. But then really needing a plan for genetic counseling, which I think is the hard part. So knowing who the MFM genetic counselors are that you're going to work with. LabCorp and Natera have their own genetic counselors. And so you can just establish a relationship with these labs where all the patients can be referred to them, even to talk about residual risk if they're not joint carriers, talk about manifesting carriers, and just go over the limitations of the test in general. So having that relationship set up. Or GeneScreen is another independent genetic counseling company that patients can be referred to, and they take insurance as well. So they'll do results review with the patients, even when they're not joint carriers. Okay, now moving on to IVF and genetic testing. So preimplantation genetic testing. So this is when we are doing IVF, and we are everyone should be testing really at the blastocyst stage. So, you fertilize the oocyte, let it grow in the lab for 5 to 7 days until it reaches this blastocyst stage where the cells have separated out into separate layers. The trophectoderm becoming the placenta, the inner cell mass becoming the baby itself, and 5 to 7 cells of the trophectoderm are removed. The embryo is frozen, and those cells are sent out to the genetic lab to do this preimplantation genetic testing. There's different types of PGT. So there's PGT-A for aneuploidy screening, PGT-M for monogenic or single gene disorders, and PGT-SR for structural rearrangements. This is mostly referring to the indication for the testing rather than the type of technology itself. Because there can be different technology with it, even within one indication for testing, depending on the lab that you're using. So again, this is the trophectoderm biopsy, and that's what's being sent off while the embryo is frozen and safe in the lab. PGT-A, so aneuploidy screening, the goal is to identify embryos with a normal chromosomal copy number. So 46XX, 46XY. The aim of this is to improve implantation rate per embryo transfer, to reduce miscarriage rate, because aneuploidy is the most common cause of miscarriage, to reduce prenatal diagnosis, so patients finding out during pregnancy and needing to make decisions at that point, and to enable single embryo transfer so that we can confidently have the highest success rates when putting back just one embryo, which lowers our risk of multiple gestation pregnancies. PGT-A is not going to lower the implantation rate, the cumulative implantation or live birth rate when you do IVF, because of course, when you're thinking cumulative pregnancy rates, you're looking at the whole cohort of embryos that were made. And yes, if you go through and transfer each embryo, you're going to have the same success because you'll eventually get to the chromosomally normal embryo, or the one that results in a live birth. But PGT-A is really a selection tool. So it's helping to prioritize the embryos that are chromosomally normal that have the highest chance of success per embryo transfer, not per retrieval. Because looking at the kind of overall morphology of an embryo, surprisingly, does not tell you the ploidy status. And PGT-A is the most common type of testing we do. Over 99% of our patients, at least at RMA, they do PGT-A. And the reason that it's so common is because aneuploidy is so common. So even when we are in our 20s at our most fertile, this is data based on biopsied embryos for IVF, for either embryo banking or fertility. And so even 10 to 15% of embryos, so that's embryos that made it to this blastocyst stage, they're aneuploid. So this is percentage of aneuploid embryos by age. You can see how that increases over time, and in your 20s and early 30s, it's relatively similar. The slope is a lot more similar, and then after 35, you start to see that slope change more significantly. So that's the reason why aneuploidy testing on the embryos is so common, is because aneuploidy itself is just so common. And why is aneuploidy common? Well, I mean, we could talk a lot about that, but here's one slide I took from Dr. Foreman, which is, I love this example of like meiosis is just easy, right? Because there's so many different possibilities that can happen when the chromosomes are separating, when the chromatids are separating. So there are only a few, the green options here are the only ones that can result in a chromosomally normal embryo, whereas there's a lot of errors that can happen with meiosis. And this more commonly happens in the egg. So a lot of the machinery that's responsible for separating the chromosomes during meiosis ages and can make more errors over time. Eggs are also never actually haploid, even though we talk about them being haploid, because you need half of the DNA from the eggs and half of the sperm. But in order to complete meiosis, by definition, fertilization has to happen. So now the next set of chromosomes are already in there. So eggs are never truly haploid. So there's really not kind of this checkpoint to make sure there's the right amount of DNA. They're used to having more DNA than expected. The method for PGT-A in this day and age is next generation sequencing. And a lot of platforms will use single nucleotide polymorphism support, which I'll show you some examples of actually. So limitations of this are mosaicism. So sometimes the report can show an intermediate copy number, basically, in the DNA that they amplified on one of the chromosomes. So either instead of having 2 whole copies, maybe and not having 3 copies, maybe showing like 2.5 copies. And we can have a whole lecture on mosaicism separately, and then segmental aneuploidies are the other thing. So showing one area, one small part of a chromosome that is completely missing or completely duplicated in a sample, and what clinical impact that has. Again, kind of a separate talk, but there are limitations to it. It also doesn't test for single gene disorders on its own. And I'll show you how we can test for that with a different method. So yeah, just going into, this is just some of the old kind of technologies that used to be used for PGT. So FISH or qPCR, microarray used to be used for PGT, but now most platforms use next generation sequencing. So again, DNA fragmentations, prepare the library, attach adapters, amplification, and then all these sequences are able to be made at the same time. And then those are mapped to the specific chromosome. And then you read based on how many parts of chromosome 1 that were amplified and mapped to that chromosome, how does that compare to chromosome 2, chromosome 3, chromosome 4? So this is always giving you a relative amount of DNA. These are relative to each other to tell you how many copies of a chromosome you have. So this is what the output data looks like for a PGT-A report, or can look like, depending on the lab. But this is looking at copy number, and this is a bunch of different reads on each chromosome. And so it's showing the amplification of all the DNA, and then these are the areas that were mapped to each chromosome, and this is how the amount of data compares chromosome by chromosome. So we can see that there's 2 copies of all of the DNA of all the areas that were mapped on a lot of the chromosomes. And then for chromosome 7, there was only 1 copy of the DNA that was amplified. And for chromosome 8, there were 3 copies that were amplified. So, this would be a monosomy 7, trisomy 8. And this is what you're looking at. This is kind of the copy number reporting that you're getting. The other piece of it that, again, some labs are using either solely or in combination with NGS is SNP reporting. And so, again, there are many sites throughout the genome where there is variety at a single nucleotide. And in general, you expect it to be one nucleotide or another. And so it can either be, A or B. And so for each site, because the embryo should have inherited 1 copy from each parent, the site is either going to be AA, AB, or BB. And you expect a distribution of that throughout. You expect there to be some BBs, some ABs, some AAs. So you want to see this 3-line pattern. If the embryo only inherited 1 copy of one of the chromosomes, like chromosome 2, then there's not going to be those 2 copies. You're never going to see A and B, right? You're only going to see that it inherited A or B. So you're going to kind of miss, you're going to find it that there's none of this A plus B area here, and it'll either be A or B, if that makes sense. Anyway, this is another tool that can be used to kind of support the NGS data to show if there is the expected ratio of polymorphisms in the sample. All right, now moving on to PGT-M, monogenic disorders. This is used when both partners are known to be a carrier of a recessive disease. So if 2 patients are each a carrier for cystic fibrosis, or when one partner is a carrier or affected by a dominant disease. So someone is a BRCA carrier and wants to have the test done. This requires customized test creation. So the genetic report that the patient had that gave them the diagnosis needs to be sent to the PGT lab so that they can review what the gene is and where the location is, and make sure that they can create an accurate test that will be able to actually pick up if the embryo inherited both copies. So they need to make sure they have good enough kind of resolution or amplification of that area. And there's 2 different ways that they can then test for the specific gene disorder: through linkage, I'm going to show examples of this, and through direct mutation testing. So again, I'll show pictures of that. But linkage basically involves tracing which parent and which chromosome the variant is coming from. And often you need other generations, whether that be a grandparent or an affected sibling, to know, to kind of track where the gene is coming from on which chromosome. And when patients have a de novo mutation, or their parents are not alive for testing, it can make it either challenging or sometimes not possible. And most labs won't accept a case for PGT-M if they don't think their technology can reach a 95% accuracy minimum. Recombination can cause a problem for picking up linkage, because if you're just tracking, which chromosome is being inherited, with recombination, that can that can affect the result or make it more confusing. And then you're also faced with the potential that you have no unaffected embryos, and you kind of have to have a plan for what you might do in that case, depending on the disease itself. Would you be willing to transfer an unaffected embryo? Will you be willing to cycle more? Depending on the severity of the disease, sometimes clinics won't approve transfer of certain embryos. And so kind of good to have these conversations in advance. So these are examples. So this is kind of trying to explain the different testing that can happen for PGT-M. So this top part showing linkage, and sorry for this gendered language here, but basically it's showing the locus where the variant, the mutation, is on this chromosome, and these are the patterns around it. So just it's marking it as a red, and this one is yellow, but in reality, you're looking at the SNPs and the short tandem repeats that are upstream and downstream from the actual mutation itself. And we want to look at that on each of the chromosomes, because this yellow and blue also has this gene, but they just don't have a mutated variant. And so you're looking for basically the fingerprint of the chromosome around the gene itself. And then when you have the embryos and you're testing them, instead of testing for that exact mutation, sequencing of that exact mutation, you're looking for that fingerprint around it. So if the embryo inherited what's upstream and downstream of this mutation, then that's considered affected. If it inherited both of them. If it's inheriting the upstream and downstream where this mutation is, and the upstream and downstream of this chromosome without a mutation, then this would be considered a carrier. So this is not testing for the specific sequence of the gene mutation, it's testing for inheritance of the chromosome. So that's linkage. But you can also directly probe the area, so the exact variant that you're looking for, and you need to know the primers, get the primers and know the areas around it, and amplify the specific gene, and then have some kind of a test or sequencing to actually study the exact sequence, or to detect if it's actually there. And so a lot of times PGT-M will involve both of these types, ideally, to increase the accuracy of the test. Hopefully that made sense. Okay, and then non-disclosure versus exclusion. So I think this is just kind of an interesting topic, that these are for gene disorders that patients don't necessarily want to know that they are a carrier for, but they know that their parent is affected. So if someone has a parent that has Huntington's disease, for example, they might not want to know their carrier status, but they want to eliminate or lower their risk of having a child affected by it. And it's actually possible for the lab to do this kind of testing. And there's two different ways that they can do it. There's called non-disclosure PGT and exclusion PGT. So for non-disclosure PGT, the PGT lab itself internally, it determines the patient's status. So they find out if they are a carrier of the specific gene disorder. PGT-M is always done in combination with PGT-A, so looking for aneuploidy. And then the embryos are marked recommended for transfer or not recommended for transfer. So it's not specific the reason why they're recommended or not recommended. So it could be because they're all aneuploid, or it could be because they're affected, even though they're euploid. So it's not clear to the patient or the provider whether the embryos are affected or aneuploid, and that's why they're being discarded, or that's why they're being marked not recommended for transfer. So the patient and the provider themselves don't have to know the patient's status. The downside being liability, that the lab does know that this data is available and not being shared with the patient. Obviously, it's with their consent, but still. And then there is exclusion PGT, where the patient's status actually remains entirely unknown to the lab, the patient, the provider, and they just do that kind of linkage testing where they are seeing so they have to look at the parent's DNA, like the grandparent of the embryo, the parent of the patient, and look at those markers around the gene, and then see which the genes and then see which chromosome from that parent was inherited by the patient. And then look at the embryos and see when that chromosome that was inherited from the grandparent that's affected was passed down. So any embryos that inherit the allele that's passed down from the affected grandparent, so not knowing if it actually has the mutation or not, but just that's the allele that came from the grandparent, those embryos are all excluded. Which means if the patient is not actually a carrier of the disease, then you are potentially excluding healthy embryos that are not affected. They just inherited a copy of their chromosome from that affected grandparent, but it was the unaffected copy. But that's kind of the way of patient, provider, and lab all not knowing the patient's status, but does risk excluding healthy embryos if the patient's unaffected. And then the last type of PGT is for structural rearrangements. So this is for patients that have a translocation, inversion, deletion, duplication. So the goal is to identify embryos that are chromosomally balanced. So talking about as a limitation here, but often you can't tell if most labs don't make the distinction if they're balanced translocation carriers or non-carrier euploid embryos. So all it's looking at is that copy number variation. So their relative amount of DNA that's present, not showing exactly where it is, but showing that the embryo has all the DNA that it needs, but not telling you whether that's because it's in the setting of a balanced translocation or if it's truly a non-carrier euploid embryo. The lab has to also review these genetic reports before saying that they'll be able to do the test. They have to make sure that the resolution around those breakpoints where the chromosomes are either inverted or connected to each other is good enough to give an accurate result. Another problem is that, not a limitation of the test necessarily, but that translocation inheritance often doesn't follow Mendelian genetics or doesn't follow the expected ratios that you expect them, that you predict them to based on how they should be passed on. A lot of times the patients are at a risk of making higher than expected abnormal embryos. And that's why patients with translocations have an even higher than expected pregnancy loss rate. It depends on the translocation. So it depends on the location, the amount of DNA, the location of the centromeres, so like how they're going to line up during meiosis, and all those things can skew it towards making more abnormal gametes or making more normal gametes. So just kind of showing what that looks like here, are examples of, this is an example of a balanced translocation, and then the DNA still needs to match itself up. The chromosomes still need to pair themselves up with their kind of matching part. And what that means for a translocation is that they have these kind of different setups or arrangements. And then they either go through alternate or adjacent separation of the chromosomes. And again, how they separate or what's kind of preferred depends on the exact translocation. So it can be really hard for these patients to get balanced embryos. And again, it's only seeing the balanced amount of DNA, not whether it's truly euploid, so they could still be passing down their balanced translocation. And that's kind of a bigger discussion around whether we should also be doing linkage or something for these patients, which would further limit their potential embryos. But I think it still provides people with more information, more choice. Should they have a totally non-carrier euploid embryo versus a balanced translocation embryo, that could affect their decision, but it would change the test that's being created and the results being given. And I did put in one slide about PGT-P, which is pre-implantation genetic polygenic testing. This is not kind of recommended routinely, but it is something available that patients might be seeing or asking about. It's genome-wide genotyping of embryo DNA and then calculating these risk scores that they're called polygenic risk scores for these common complex multifactorial diseases. So things like type 2 diabetes, coronary artery disease, schizophrenia, and a number of other diseases. The goal of this type of testing is to rank embryos by predicted lifelong disease risk. And so again, another selection tool, but it's really important to remember that it's just providing a relative risk for that disease within a small cohort of embryos. So this is not an absolute risk, and there's not long-term studies on this to see how it actually translates. It doesn't take into account how the genes interact with the environment. And so I think most people, most RAIs are not using this, because I think it raises kind of more questions than it does answer sometimes, and further kind of puts fear into patients and limits the embryos that they have that are usable. And then it creates, this is the best morphology embryo that's chromosomally normal, but it has, a slightly higher risk of type 2 diabetes than this other embryo. And how that translates to something clinically meaningful is sort of not clear yet. So many people are not using it yet. So then just thinking after conception, the prenatal testing and POC testing that you're doing. So cell-free DNA and NIPT testing that you're just doing on maternal blood samples. There's different technology depending on which test you're ordering. So like Maternity 21 uses more like NGS kind of testing. Panorama uses SNP testing. So it's looking at the relative ratio of the SNPs, the maternal SNPs versus the fetal SNPs. And then Illumina, I don't know if people are using that, but it does whole genome sequencing more so. So there's different technology depending on the test that you're using. And then, like I mentioned, with CVS, amnio, POC, and with cell-free DNA, really, the resolution of these different tests are going to depend on the amount of DNA you're putting in. So you can get a lot more information and to a lot smaller size using microarray on a CVS or amnio sample than you can from PGT, because you're just putting in 5 to 7 cells worth of DNA. So whereas a microarray for CVS or amnio can get you to the kilobase size, for PGT, when we were using microarray, it still would only go down to like 5 megabases. So, and then just to touch upon actually whether patients who did PGT and transferred a euploid embryo, whether they should do cell-free DNA or NIPT testing, if they should do diagnostic testing. So 2 points. I mean, the prevalence of having an aneuploid pregnancy after transferring a euploid embryo is going to be a lot lower. And so if you do get a positive cell-free DNA result, the positive predictive value is going to be a lot lower in these patients, because already their pretest probability is so much lower. And so they should still be offered this. It can still be valuable, but it's less than 1% is what at least one study has shown on detecting an aneuploidy in a full aneuploidy through NIP testing. If anything, if patients do end up positive, the likelihood of it being a true positive is very low because of the pretest probability. And then for CVS and amnio, so same kind of goes. But also just to kind of reiterate that obviously PGT does not detect everything, and it cannot detect these small microdeletions or syndromes that are so associated with those. So still the same benefit of CVS amnio applies to patients who did PGT as your general OB population. So you can still, I wouldn't do it, or it would be less valuable for whole chromosome aneuploidy, but there is still other data that you get from these tests that are just valuable to the general OB/GYN population. So that's like most of my talk, and then just thinking about other relevant genetic tests in the world of OBGYN. So recurrent pregnancy loss, looking at karyotype for translocation, premature ovarian insufficiency, looking at their Fragile X carrier status and karyotype. There's PCOS mimickers where they might be carriers for non-classic congenital adrenal hyperplasia, which you might start with hormone testing for that, but can be picked up on genetic testing as well. And then oncogenetics, BRCA, Lynch syndrome. So it's just to say there are, and there's so many more that I'm sure I'm not touching on, but there's all these different ways that genetics come into play in the world of OBGYN. Again, that's most of my talk, but just to briefly touch on the future of genetics and some things that you kind of see in the media that are interesting, that are, we'll see kind of increase over time is mitochondrial replacement therapy. Those are for patients, especially with mitochondrial diseases. And there's kind of two different ways of doing it, but where they actually are taking out the maternal spindles. So the nuclear DNA essentially of the oocyte and inserting it into a donor oocyte that had its nucleus removed. So now you're using the mitochondrial DNA of the donor egg while having the nuclear DNA of the intended parent. So that's one way of doing it, or by fertilizing the oocyte with the sperm and then removing the pronuclei of the fertilized of the zygote and putting it into a donor egg. So that's one thing that's kind of cool that you'll see in the media. In vitro gametogenesis is very interesting. So this is where you take somatic cells and reprogram them to become induced pluripotent stem cells, and then further make them into primordial germ cell-like cells, and then differentiate them as spermatogonia or immature oocytes, and mature them, and essentially make egg and sperm out of skin cells. So kind of give the skin cell, or give it whatever cell the skin cells usually would think of, give them back their potency, and then ultimately make them into egg and sperm to use. Again, I'll talk on that. And this has been done in mouse models. So this has been done successfully, where they've implanted the primordial germ cell-like cells back into a female mouse or a male mouse, and they've actually made eggs or sperm and made viable embryos. And recently, you might have seen it done with some human DNA as well. And then, germline genome editing, like CRISPR-Cas9 technology, having the ability to, whereas with PGT-M, we're just testing for the presence of a gene disorder, thinking about genome editing, where we can actually test for the presence and then correct the gene disorder. That's something potentially of the future. Right now, it's really good at making cuts in the DNA and creating mutations, not as good at repairing it, but becoming more possible. So in summary, preconception counseling appointments really provide opportunity to set patients up for success for their long-term family planning. As much as it feels like it can take time, you don't know exactly what they're looking for when they're coming in for a fertility check. I really think that this is part of what it's opening the door to discuss. Universal carrier screening and IVF genetic testing can provide patients with education, autonomy, choice. It can prevent or at least lower diseases, lower the likelihood of diseases in future generations, and can ultimately improve outcomes. And collaboration between clinicians, labs, and so importantly, genetic counselors ensures that the safe and effective use of these genetic tools. So thank you.
Thank you, Dr. Bergin. We're going to now begin answering questions today that's submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Our first question is there a panel that you recommend for OBGYNs, and do you test both partners at the same time?
So there's not one specific panel that I would recommend. I think it's depending, it has to be depending on what your workflow is in your general OBGYN office, and communicating with the labs so that you have a workflow that they're being contacted with abnormal results, or they're being contacted with the opportunity to discuss even just their discordant carrier couple status, what it means to be a carrier when your partner's not a carrier, what the residual risk is, what it's not looking for. And so I think that reaching out to, whether it be LabCorp or Natera or Fulgent, one of these panels, a lot of them offer this, or establishing a relationship with GeneScreen, and figuring out what your workflow will be for that. If you are affiliated or have an MFM office that you refer to, you can also find out from them what their genetic counselors are recommending. I'll tell you, we use LabCorp or Fulgent. Most patients are covered for this genetic testing. So that's another thing, just a point about ethnicity-based testing. When you're like adding on these like smaller panels, cost-wise, it actually just makes sense to do the large panel. It's often cheaper actually than adding on different small panels and needing to figure out what to order. And so most patients are actually covered through their insurance, we're finding. And then a lot of them, like Fulgent and I think LabCorp soon, I think it's like $250 if out of pocket would be the max for patients that are not covered. And so we're testing patients at the same time. Test results can take 2 to 3 weeks. So and most patients are not wanting to wait, ultimately 6 weeks to start, because majority of people are a carrier for at least one thing. So when you're doing these large panels, over 50% of people will often be a carrier for at least one thing. And so we're doing it at the same time. If patients are not covered for the testing, that might be a reason they might consider doing one partner and then, deciding if it's worth doing specific gene testing or a full panel on the second partner. Again, often it's a similar cost for the full panel as it is for like some of the individual gene tests for out of pocket. And during pregnancy, I would recommend them being tested at the same time because that's just going to further delay decision-making later into the pregnancy and stress during the pregnancy. So I think during pregnancy, even more important to test patient and partner at the same time. Ahead of pregnancy, depending on their timeline and their coverage, kind of a shared decision.
Thank you. The next question is, can you perform more than one PGT at the same time, and is that necessary? Meaning like the PGT-A, PGT-M.
Yeah, so for all PGT-M cases, we always perform PGT-A with it. So yeah, we're wanting to know if the embryo is chromosomally normal, as well as if it has the single gene disorder that we're testing for. So we're always doing it to PGT-A with PGT-M. And yes, if patients are carriers for more than one thing, which we definitely have, they're a BRCA carrier and them and their partner are cystic fibrosis carriers or something like that, then the lab has to create different specific tests for their inheritance of those things, but they can be done together.
Thank you, Dr. Bergin. That was our last question. Thank you everyone for attending today's webinar, Genetics and Fertility. If you have any other questions, you can contact myself, Alyssa Cooper at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey of the presentation, and we would appreciate it if you can complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, RMA of Southern California, the EVRMA North America Network, and Dr. Bergin, thank you for joining us today and enjoy the rest of your night. Thank you.